Today's talk is on disruptive behaviors. And with us today, we've got Haack, who is also a clinical psychologist, who has practiced in the hyperactivity, basically our ADHD clinic, our health ADHD clinic. And so she knows a lot about what she speaks. Dr. Neal Rojas, one of our developmental behavioral pediatricians, also helped to put this material together, but unfortunately, he is feeling ill today, and so he can't be present. But a lot of his great thinking and ideas went into this presentation, so I want to acknowledge that. I am going to be doing my best to pitch it for him and to share his material today. So our disclosures, meaning that so none of us have relevant financial disclosures to share, and CAP gets federal and state funding that you can see here. And these are mandatory disclosures that we show you. So I'll leave that up for you just so you get an idea of what they are. And then our objectives for today. So basically, to be able to recognize disruptive behaviors and when they become disruptive behavior disorders, that we can actually diagnose using DSM criteria. We want to start learning about some behavior management tools, okay? So that we're not just saying, go out and look for these parenting classes that may or may not exist, but that we have a few things that we can offer directly to families right there in the office that may be helpful. But there are actual evidence-based psychosocial treatments that are out there, and we should know at least what they are. And if they exist, to find out about them in our community, and if they don't exist, to see what we can do to advocate to get them more commonly available. But there are online resources as well, which can be offered from anywhere that has an internet connection. And then finally, there are limited roles for medications in the treatment of disruptive behavior disorders, although as we will learn, they are not first line. And so there will be a brief discussion about this as well. Okay, so with that, what do we mean by disruptive behavior, right? Like it's a wide spectrum, and it ranges everything from totally normal toddler behavior, like a toddler who's biting when he's frustrated or she is frustrated, that's normal, but it can be seen as disruptive, or tantrums, that sort of thing, to very severely disruptive behavior that's maladaptive and even violating, right? Like think adolescents getting involved in criminal activity. So that is a very, very wide spectrum. And I think one of our difficult tasks in pediatrics is that we see it all, right? And it can be really hard to distinguish what's normal and what's abnormal. And so what's on the slide are a few like considerations or principles that we want to think about to help distinguish, right? Distinguish the two. One is this developmentally appropriate? Like developmentally, where are they? And when thinking about their developmental age and not necessarily their chronological age, right? We also think about the functional impact. So how frequently is this happening? How severe are the consequences of this behavior? How pervasive is this? This is only happening at home, right? With particular caregivers, or is this happening in preschool, at home, out in the playground, like in a lot of different places? And rating skills can really be helpful with this, right? Because it lets us gather information from different sources all at once and help gauge the severity question of this and the frequency question of this. And we'll be talking a little bit more about what some of these tools are. Okay, so there's a large range of normal disruptive behavior that's developmentally appropriate, but then there are what we call disruptive behavior disorders that are labeled inside the DSM-5. And I've got a few of these listed up here on the slide for us today. Probably the most common one of the disorder category that we will see is probably oppositional defiant disorder. We see this all the time, and you see the criteria here. It's not occasional behavior, it's a pattern of irritable or angry behavior that's non-compliant, it's argumentative, it's defiant, sometimes it's vindictive, and it's happening chronically. It's happening for over 6 months. And that's basic, like when to think ODD. And then cognitive disorder is like a step in severity above that, where you actually have behavior that violates the rights of others, or societal norms, again, the things that could land you in jail. And generally kids who are a little bit older. There's some newer categories that I hadn't necessarily heard of earlier on in like my pediatric training or like work as a general pediatrician. Intermittent explosive disorder, okay, where you have these bursts of really, really explosive behavior that can get very like aggressive, and this could be either physical aggression or really bad verbal aggression, often accompanied with like property damage or physical assault, happening like multiple times in the course of a year. Okay, but the hallmark of this is that in between they don't seem particularly irritable. Like they seem okay, but then like boom, just like out of nowhere, like it's explosive. And I actually thought about these like explosive devices that you see in war, like you do boom, like out of nowhere, it's just like explodes and causes some damage. And then there's this other and unspecified category that a lot of things can like kind of be grouped into when there is a really big functional impact and it's pervasive and it's severe, it's frequent, it's chronic, but it doesn't quite fit into these other categories. There's this other disorder that's in the DSM that I want to call out that's technically a mood disorder, but shares a lot of features with these disruptive behaviors. And that's something called disruptive mood dysregulation disorder. And basically, it can look a bit like intermittent explosive disorder, except that in between, there's just a lot of irritability. They're just kind of chronically irritable or angry. And then it's punctuated by these like extreme temper, extreme outbursts that happen in between. And what's happening is that younger children who had previously been categorized or called bipolar are often finding themselves in this category. But their behaviors look very, very disruptive. But this is actually in the mood disorder category because of this pervasive, like irritable mood that is in between. And so these are all diagnostic considerations that we should be aware of, that we should have some familiarity with. So introducing these words to you, these terms to you. And when there is a disruptive behavior disorder, there is often a comorbidity or an underlying condition that may be contributing to the behavior patterns that we're seeing. So things like ADHD or depression, sometimes anxiety or bipolar disorder can show up this way, or trauma or PTSD can show up looking very disruptive and functionally very significant. And there can be a danger of misdiagnosis, like a kid with trauma can show up like being labeled as ODD, right? And it's not ODD, this is trauma or PTSD. And so we need to be careful, and we need to get as comprehensive a history as we can get and think broadly as we are, and consider the comorbidities or mimics as we are considering putting a label on a child. Okay, so when we see disruptive behavior that seems out of the range of some kind of normal developmental behavior, disruptive behavior, and seems functionally impairing and significant, pervasive. I think for us at the front lines of primary care, we need to do a safety check, right? It's like, is the kid safe, right? Is this misbehavior or this apparent misbehavior actually reflective of like some unsafe condition in the background, psychosocial stressor that we need to be aware of and that we need to be addressing, right? So do a quick safety check, okay? And deal with it as appropriate. Like just that may be where we stop. But if we realize, okay, there are no immediate safety concerns, then we can think about using some screening tools to help us to get our bearings on what might be going on here. So depending on the age, there are different screening tools that we might be looking at. A great one for younger kids that I like is actually a developmental screening tool called the SWIC, or the Survey for Wellbeing Young Children. How many of you guys are actually familiar with the SWIC? Is that something that you've used? Or okay, it's not that commonly known, but it combines developmental milestones, social determinants of health, and behavioral symptom questionnaire all in one. And it's a great one to use for kids 0 to 5. For school age kids, the pediatric symptom checklist or the Vanderbilts are my go-tos to look to kind of get a sense of like, Is there significant externalizing behavior going on? And so there is also a DVD rating scale that's out there as well. Okay, thank you, Joan, for giving us the link to this book. I think it's underused. I think it's underused, and it's a good tool. And I also want to call out that as we are doing our screening and as we're getting our history, younger kids in particular can be diagnostically challenging, right? Because we don't know how this behavior is going to evolve over time. And sometimes that time will kind of tell us like how this will kind of land. So is this a matter of temperament and parent-child dynamics, right? That's often the case. Is there a background trauma history? We definitely need to ask. Or is there an emerging neurodevelopmental disorder that we should be picking up when kids are acting this way, like in this really, really disruptive way? Like things like autism, spectrum disorder, or developmental delays. These are all considerations for the younger kids that we've got to think about as well. Okay, so once we do our screening and we have some idea there is a diagnosable disruptive behavior disorder, or even like non-diagnosable disorders, but disruptive behavior that is distressing the family, right? Like, what are we going to do about it? And one of our first steps that we really want to get into really is like, we've got to engage the parents, because there is no helping the child unless we are partnering with their caregivers, because a lot rides on how the caregivers respond and like what they do in response. And by the time they bring this up, a lot of water has gone under that bridge. There are likely big parent feelings along with like big kid feelings. And parents may themselves be feeling like, I've experienced a lot of like blame or shame or like embarrassment out in public, or relatives telling me what to do, or who knows what else, right? Like I have experienced a lot of pain because of this as well. And validation can be a really powerful tool in our toolbox to be able to offer to caregivers in this situation, that this is not easy. Nothing about this is easy. And you know, we can partner together and let's get into this a little bit more. And the reason why we really have to like partner with parents and not make them and not like antagonize them is that all the interventions that we're going to talk about next really ride on the caregiver, because intervening at the parent level works way, way better than intervening at the child level. So we absolutely need caregiver involvement here. And it's nice to help remind parents that when we've got disruptive behavior like this, you're going to be putting in the work, right? There's just like no choice about it. You are going to be putting in a lot of work. The question is, do you put it in up front, or are you always like kind of playing catch up or reacting to something that has just happened? And I'm loving a lot of the comments that I'm seeing coming through the chat here. This doesn't all fit into a 15-minute visit, right? There are going to need to be follow-ups, a series of follow-ups, and understanding where the parent is at is like super important to all of this. And yes, sometimes the parent-only discussion is critical, because it's really hard to talk frankly about what the issues are if the kid is there all ears and listening to all of it. So this could be a good time to get kids coloring with a friendly MA outside, like while you have like a frank heart-to-heart with a parent. So there are a lot of great practical tips here, and please keep them coming. And if others here too, like have things that have worked for you as you're trying to engage with parents and get the conversation started in addressing these, it's wonderful to like get your thoughts and ideas here too. We can have the simultaneous conversation going. And that's great. And so as John was mentioning, there is this whole ABC model where A is the antecedent, B is the behavior, C are the consequences. It's also been called the before and after model. What happened before the behavior? What happened after the behavior? And it can give us a lot in the way of like clues as to what's triggering this or what is reinforcing this behavior to happen again and again. Because usually there's some kind of pattern there to account for the fact that it is happening again and again. And there's an example here, right? Like the classic kid in the toy store, like throwing a tantrum, pitching a fit. And then mom's like, okay, calm down, I'll get this for you, right? So what is happening here, right? Why did the kid pitch a fit? Because kid wanted the toy and mom said no, right? If the mom had said yes to begin with, there would have been no fit. Then what happened after? Like mom said, okay, I'll buy this for you. And then what happens, right? There's a parent piece, but you have just kind of started to set up a pattern or an expectation where the kid gets rewarded for the tantrum, thinking this is how I get things in the future, right? And the parent, in a way, gets rewarded for kind of giving in because got like freedom from the tantrum. So basically, it's really so thinking through like this kind of like the before and the after helps us to understand what triggered this, what's reinforcing this, and helps us to understand what is the function of this behavior. Many times it's to achieve a goal, like for a kid, it's to get that toy or to get what they want, right? Or to like be able to overstep a boundary that's been set. Sometimes it's to communicate like some distress. But if there's absolutely no function that you can discern whatsoever, then think something medical or think pain. Because if there is no discernible pattern there, that's something to think about. Okay. Sometimes you can work on the antecedents, right? Like if you know certain situations are stressful for kids, you can just like reduce what some of those stressful situations are, right? There's a lot you can do there to kind of prevent like the tantrum from happening. But then there's a lot you could do in the after and the consequences to modify the behavior. And one of the tips that really helped me was this analogy that I heard that attention is like water. The behavior that a parent pays attention to is a behavior that will get repeated. It's like watering a plant, right? That behavior is that you pay attention to will grow. It will, and so if the kids are getting a lot of apparent attention by acting out, they're going to continue to act out because this is the behavior that parents are paying attention to. And so some of the behavior modification techniques rest on this like principle that you want to kind of flip things. So instead of getting a ton of attention when they're misbehaving, they're actually kind of getting attention for engaging in the behaviors that you want to see more of. So immediate praise, immediate like recognition, like of like progress, movement towards like the desired behavior. And then like either ignoring like a harmless, unwanted behavior or providing the consequence afterwards if this is something that you just can't ignore. But the idea of like flipping this and actually providing attention like water for the behaviors you want to see grow and really being like proactive about this. And so so using the attention to increase the behaviors you want to see increase, and then using planned ignoring, timeout, or loss of privileges to decrease the problematic behaviors. And there are other ways of providing immediate rewards, token systems, small incentives, but they've got to be immediate and consistent. And all of this has to be immediate and consistent. And there's going to be more of this that Lauren's going to get into.
Okay, so as Joanne mentioned, the most well-known to work treatments that we have for disruptive behaviors disorders actually are psychosocial or behavioral, and they're focused on the child's environment rather than the child, him or herself. And why do we do this? This is a question a lot of times parents will ask, well, why am I supposed to go get treatment if it's my child that's having these behaviors? And here's some of the rationale. We have decades of research showing that kids who have these disruptive behaviors, their families are more stressed out, right? Which makes sense. Think about how difficult it is to parent a child with these behaviors. We also see more conflict and chaos, and these parents feel less able to effectively manage their children's behaviors, right? So all of the parent management and family-based treatments that work really focus on this idea that we call the 3 Cs. So we were going to increase the consistency of the expectations that we have for the child and that we communicate to the child. We're going to make those very, very clear. And then we're really going to focus on celebrating, right? Just like Joanne was mentioning in that last slide, what we want parents to strive for is a 5-to-1 ratio, 5 celebrations for every 1 redirection or consequence. And so treatments that work really focus on giving psychoeducation about what disruptive behavior disorders are, what are the associated features, and then really working to improve those ineffective cycles that parents and children find themselves in. How we're going to do this is by teaching parents to have those clear expectations and really predictable consequences with much more emphasis on the positive, because that works better. And then also, especially as the children get older into the teenage years, we incorporate them more and having them really as a family unit work towards more effective communication strategies and problem solving. So there's a lot of brands of these treatments that work out there. Some of you might be familiar or have seen some of these. We don't have evidence that one brand works better than the other. So honestly, if any of these are available, I would jump on them or encourage your families to jump on them. Because again, what they're really doing is seeing this underlying principle of the parent-child interaction cycle. And so we have an example up here. So if we could advance on the slide. Here's a really common expectation that we might have for our child, right? We're going to tell them, put your backpack away. All right. And then if we advance, let's say the child doesn't comply, right? What do you think a parent is likely to do if they ask their child to put their backpack away and they don't do it? People could feel free to put in the chat or unmute. What do you think the parent's going to do next? Ask again, absolutely. And do you think they're going to ask in the very same way? You got it, Kelly, right? If we advance, they're going to probably say it louder, maybe more angry, right? Like, put your backpack away. So let's say at this point, the kid does that, right? Well, now the parents learned I have to raise my voice in order to get my child to do something. And the child's learned my parent doesn't really mean it until they raise their voice, right? So they're probably going to start right there next time. But let's say if we advance, let's say the child still doesn't comply after they've yelled. Now what might the parent do? What might the parent do if the child's still not doing the instruction even after they've repeated it, maybe a little bit louder? Okay, so maybe take things away. Those are very effective strategies. Make a threat. That's probably more likely, right? Get frantic, try to negotiate. And if we advance the slide, let's say they're late for school. They've really got to go, right? They might just do it for the child if we hit advance on the slide. So then we've learned, right? The child's learned, well, I don't really have to do this unless my parent makes a threat, unless they're, trying to negotiate with me, or maybe I never have to do it because they just do it for me. And the parent learns that they have to make threats, or they might just have to do it for their children, right? So by the time you're seeing these families in your office, this cycle is likely very ingrained. And so it's really going to take some outside support most often to get them to a place where they're able to flip that interaction cycle on its head. And so I can pull up the slides here if we're having trouble. Oh, there we go. So what are some of the strategies that we see across these parent trainings that get us to flip the cycle? Right. So in order to increase consistency, one really nice way to start is just by increasing special time, or what we call time in. Joanne's going to talk a little bit more about how she pitches this in a pediatrician visit. We can also talk about how to communicate, give effective instructions, have routines set up ahead of time, how to give those consequences for misbehavior, right? Having a plan for removing privileges rather than just in the moment having to come up with something, because when we're frustrated, we're probably going to have a bigger, more harsh, less able to hold consequence, right? And then we also want to teach the whole family system strategies for managing stress and emotion, because we interact better when we have our stress under control, right? And then again, really focus on those positive consequences for even baby steps in the right direction, how to give really specific praise and how to give rewards. So we know it can be really hard for a lot of families to actually access these treatments that work. They might not be available. They might be too expensive. The wait list might be long. It might not be in their language. I saw someone ask in the chat about culturally sensitive treatments, and actually, in general, these family interventions tend to show really good effects across racial, ethnic backgrounds, across different languages. And there are some that have actually been tailored for specific groups. Triple P, for example, in Incredible Years has a lot of different adaptations for different cultural groups, but actually finding those with open wait lists that families can afford and be able to take the time to go to is not always as easy of an ask. So we do have some online resources compiled for you all. You'll also get a handout where you could actually just give these to families, and most of these are available in English and Spanish. And so these are ways that you can kind of get the family started as they're trying to navigate actually finding more support in, say, a full parent management training curriculum.
So one of my favorite things I like to do is talk about special time or time in. And basically this is like, it's dedicated, scheduled, regular time that you have just like one-on-one undivided attention on your child. So you're not doing chores along with it. You're not looking at your phone at the same time. And the kid picks the activity. And the whole idea is that you're having fun together and you're enjoying each other's company. It doesn't have to be every day. It doesn't have to be super long. It just has to be regular. It has to be predictable. And kids have to know that it's coming. And you're basically following the kids' lead as to like what they want to do. I think of it like money in the bank. Like every time we need to redirect our child, there's some like one of those like cycles happening, that's money out, right? This is money in. And it tends to reestablish motivation in the child to try to do that hard work of changing their behavior, of like listening and like doing things differently than maybe they had been doing before. And so I often find that it doesn't fix everything, but it often lowers the temperature. And so things don't feel quite as like in crisis as we may have before when families start doing special time regularly with each other. And if I've got one thing to pull out that I can talk about, this is often it. And the other important piece, like when we're talking about behavior management, is that it might get a little worse before it gets better. Because if there wasn't really a consistent limit before, and now you're putting a consistent limit in now, there's this thing that I think most of us has heard about. It's the extinction burst. It's like that broken button in the elevator, right? Before they're used to pushing a button, getting a certain response, right? Throw a tantrum, I get my way. Now you throw a tantrum, you're not getting your way. You pressing that button again and again and again and again until you finally convince yourself this button no longer works. So you're going to see an increase in this challenging behavior before it goes back down. And you may get little bursts here and there along the way, but it's good to give parents a warning that this might happen. And then, as we said, psychosocial treatment, like what Lauren described, this is first line for disruptive behaviors in general. And so things like special time, other tools that parent management training programs give you. That's all parent focused. Sometimes as an adjunct, you can institute child focused treatments like individual psychotherapy, like cognitive behavioral therapy for the kids, but there's a lot more evidence that the parent level intervention does more. But also a second line, you can consider some medications. So, and that's largely geared at the comorbidities. So if ADHD is present, then you can consider stimulants. For maladaptive or impulsive aggression, sometimes I have pulled out guanfacine or alpha agonists. And then if they need more than that, my personal practice generally has been to refer onto psychiatry. But the agents that might get used would be atypical antipsychotics or mood stabilizers. And I'm not sure that any of us pull these out on a regular basis. That's generally when I refer. These are some great resources and books these will be coming out on a handout that we will be posting and sending out after today's talk is over. And so with that, I realize, and here are some of the online parent management training programs that we talked about and resources that we will send your way.